Hey, Sally, how you doing?
Oh, hi. Who's that?
John.
Oh,
How you
sweet.
doing?
Yeah. I'm alright, you?
Oh, not bad, not bad. Looks like we'll have some vaccination certificates. Oh, man.
I've already played with the beta.
Yeah.
I played with the beta a while back, but yeah.
Yeah, we're going to do a beta release of the actual cert creation process as well. So it's going to come out on the 8th of November. So
Wait, add me to the beta testers if you want, if you've got a list. I'm on the COVID one. But...
What's your email address?
Oh, do you need my Apple one or is just my work one alright?
It's the one you've created for the My Health account.
Oh, that's a good question.
Yeah.
Oh.
Whatever it is, send it through and I'll get you added.
I tried to log in with Real Me and then it had a hissy fit.
Yeah, that would be
I think it's sal@area51.gen.nz. Now I'm showing my age.
I think you need to email me that because I'm going to forget it.
I'm showing my age. It was before the .co's.
Yeah.
I just didn't get rid of it because it's cute.
I love that.
Hey, Richard.
Hi.
Hilda.
We actually have cameras on this week. This is better. Oh, we only had a few on the screen last time I was here.
Oh, is that right?
Yeah, people turn their cameras off because they try to do 2 or 3 things at once.
Oh, I just do 2 or 3 things at once anyway.
Yeah. If I act distracted, it's because I'm trying to do 2 or 3 things at once. I like it. So.
No, what was I going to say? I just get frustrated with the students because you have a class of 200 and you're the only one with your camera on. It's like
I tell you what, young people these days, Sally, isn't it? You know.
You're making me feel old. Thanks.
No, not at all. Hey, not at all. I totally appreciate it. I did a lecture recently, a guest lecture recently, and you know, you're talking away and you're trying to engage all of the students, and they gave me a little bit of background in terms of who they were. And so you're talking away and you're trying to engage them, and they're just sitting there and like they might even be on their phone. You can see their phone and they're on their phone, and you're like, and you're like, do you have any questions? And the answer is, no, I don't have any questions. Or they just look at you. They look at you as if you're crazy. Why are you even asking that I've got questions? So it's a funny thing because you kind of end up in this. I'm trying to do a really good job here, kind of catch me too. And by trying to do a really good job, you're trying to almost over engage with the students, and so then they're like, "Oh, that's so not cool. You shouldn't be doing it like that."
I can stand not being in person with them. It's hard. I like to.
Yeah.
But, what was I going to say? It took me 6 weeks to turn their camera on, one of them.
Oh, really? Weeks.
Weeks. It was entertaining.
Yeah. Hey, Diana, Anya, Justin, and I can see Dean's got his camera off and he's muted, so he's probably just listening, so that's fine. And I'm assuming some other people are going to continue to join. So here's Ben, who got to introduce himself last time. And oh, that's a very nice photo in the background there, Ben. Where is that? Is that London?
Sydney.
So yeah, let's have the guesses.
Have the guesses.
Who else?
It looks like the Anzac. Oh no, I thought it might be the Anzac Bridge in Sydney.
Yeah. Oh yeah, I can see why that might be. Yeah.
I'm looking at the bridge in the background, then I'm looking at the building in the background as well.
Yeah, I'm looking at the bridge.
That's what I was trying to figure out too. Hi, Justin.
It is in Europe. I'll give that much.
Ooh, it is in Europe. Maybe it's France.
Further east.
Further east. It's not in Germany, is it? I thought it might have been
south.
No.
Yeah, south of Germany. Yeah.
We'll get there. I'll keep guessing. Somewhere in Italy, then.
Further north.
I think you should start every meeting with someone having a picture, and you have to guess where it is.
So there's actually a game. Did you know there's a game that I'll dig it out while we're having the conversation, if I can. but my son plays it. It's called, I think it's called Geotagger or something. And so basically, you get this random photo, and it's kind of zoomed in on Google Maps, and you have to figure out where in the world that photo is. So he plays it a little bit. So there you go, a little game.
Geocaching.
Yes.
When you can't find a logbook to take a picture of the geocache.
Yeah, there you go. Or someone's hidden it or broken it or taken it away, because people do that sometimes. So Ben, are you going to enlighten us as to where this is, where this photo
Sure.
is?
So this is taken from the Gothic Room in the Buddha Castle. So in Budapest. So that's looking on the Buddha side, looking back towards Pest, the Pest side of it, and that was actually where we got married. So
neat.
So it's pretty pleased with that. Yeah.
And it's a pretty unique view, I guess. Then, do you know what I mean? Like when you think about it from a New Zealand context.
Yeah, it is, and obviously fond memories for many reasons. Yeah.
I was going to say, I know where Richard is. MIQ.
Yeah, it's just, where's my MIQ?
Yeah, that's
Oh,
true.
I wonder
Where are
where
you?
that room is. Yeah.
Hey,
Yeah,
where
it's
was
our
it? I
hotel.
missed.
I'm down in lovely Mangery.
Very good. Very good. Welcome back to New Zealand, Richard.
Yeah, back. Yeah, I've been away for 3 weeks, so this is me back now. So
Very good.
thank you.
Well, we might get started on the call
because I might get dragged away by a nurse in a minute.
Oh, to do your daily check.
Yeah.
Dragged away.
Very good.
Be nice to the nurses. No, only kidding.
To get a swab up your nose this time.
To get a swab, day 3 swab. No, the nurses are lovely. They're all lovely, actually. All the staff.
I'm teasing.
Very good. So we might get started and start having a bit of a chat about what we've seen in the news. So I tried to post a picture earlier because Sav had responded to something on Yammer, and I don't know if you can see the picture or whether you can you see it on the web. So it was a picture of something that came up in the last. Sorry, someone's phoning me. A picture came up in the last over the weekend, and it was a big yellow box. And turns out over the weekend it was the 20th anniversary of the iPod. And so on a website called panic.com, they've got a wardrobe full of stuff, and there's an almost released prototype of the very first iPod, except it doesn't look like it at all. And so kind of long story short, I posted an article this morning about how do we bring design to medical devices. And the yellow box reminded me of what I saw on TV last night. So there's a trial going on in Dunedin of closed loop insulin therapy. So glucose levels and then administering insulin. And the box that they've got for it doesn't look very sexy. It doesn't look very nice. And so I looked at it and I went, oh. And then I saw that article and kind of connected 2 and 2 together, and then added in the iPod anniversary on the weekend to that. So all very interesting. It's odd to think it's 20 years old, and imagine how far things have come in 20 years from the very first iPod to kind of the iPhone 13. Things have changed a lot, and it reminds me of a quote from Bill Gates, who said, we tend to overestimate the amount of change that happens in 2 years. Yes, nice one, Sally. Overestimate the amount of change in 2 years and underestimate the amount of change that happens in 10 years. So it's a really fascinating thing. Does anyone else have any news they want to share? Things, because we've not talked in a little while. So what have people been doing for the last month? Interesting things, I'm hoping.
We've got a clinical trial in WDHB.
What's that about, Richard?
EEG neurofeedback for chronic pain, 116 patients. Yep.
Tell us more.
Yeah, well, I mean that's the short version of it. We've got our EEG device called Axon, brain computer interface neurofeedback device. We did a proof of concept last year in the UK. Got really great results from smaller numbers. And now running a 116 patient trial in Waitemata with AUT researchers, Waitemata pain team, and going good so far. We have an online analytics program, and although there's a sham control and the patients are blinded, etc., we can see who's getting a result and who isn't, and that's where you would expect it to be. There's also a cohort of 20 people in the UK joining that in East Kent in NHS.
And so was that so that you got to go for a free holiday to the UK? We'll edit this bit out.
I didn't go to the UK for that. I actually went to Dubai to find money to pay for it all.
Oh, right. Yeah, fair enough. And so the sham trial, is there a light on the device or a noise that goes bing in order for people to feel convinced that even though it's not working, it is working?
Actually, we've done something that nobody's ever done before in that space. Usually there's a sort of video of somebody's previous successful treatment played to the person. And what we've done is we've actually taken a mixture of their real-time EEG so that all artifacts and things show up. So if they move around, they're warned to sit at peace and stop moving and things. But the feedback that they're receiving is actually a stream of data from a previous patient or previous patients, numerous patients actually that randomly selected that got a good outcome. So it's a mixture of live and fake data, rather than video. Yeah, so yeah, very sophisticated sham, binding the two of those together.
Very nice, very nice. Has anyone got any other news they wanted to share? Diana, I know you've got news.
Justin, go first.
I was actually trying to make notes. I'll need to lean on Sav because I'll probably forget stuff. I'll go quick fire. So coming back to the point around the role of design in medical technologies, I've been busily hiring designers. So I've had 2 offers go out this week for more designers to join a particular work stream. I think there's no end of opportunity for design. That's where Adam and I were started partnering with the design schools. So we've got 2 PhD students from Vic Uni looking at our restricted extremities issues. So someone who's had their lymph nodes removed and how we communicate that rather than writing in a vivid on a person's arm, don't cuff this arm, which is an interesting problem. Sav's been working with Professor John Windsor on his Epicure device and how we do usability testing on that so that it's not a scary thing that gets stuck to a human without talking to the actual humans. So we've been doing a little bit there. And we put in a pitch to BIA. So thank you, Eileen and Ben and Anya and also Richard Perry. So from Capel and Coast. So we've put that Lean Canvas pitch in and we'll hear next week. What about pediatric device design? Yes, we did have a Massey PhD student looking at the collection of midstream urine samples from kids, but it wasn't really a good product for the hospital. So she's going out to primary care actually. So she's going to, so she's taking that product out to primary care. And we've had David White in from the Biodesign Lab promoting his work around autonomic nervous system activation, talking to our sleep lab. So they're discussing what research projects are going to fire up there. So we've got the research, we've also got the University of Auckland Architecture School reaching out. So basically shed loads going on and we're trying to work out how to live with COVID. So the timing's not great. So I'm just trying to work out how to just manage the timing. Sorry, Saab, you're going to jump in there?
No, sorry, I just said and it was sleep lab and respiratory.
Sleep lab and yes, sleep lab is part of the respiratory service. So so we've got shed loads going on, and I'm trying to find projects for Victoria University's Masters of Design program. And one of our new friends in the human factor, he teaches human factors at the University of Auckland. So if you guys have got problems to solve that you think master's students could work on from design or might be human factors problems, I can help connect that up.
Cool. Diana, do you want to go next? Tell us your news.
Yeah, sure. So this week we finally are able to unveil Te Toki Mataora, the MedTech Research Translator, which is a new program that's started up to look at the research translation capability for New Zealand. And it's open to all universities, CRIs, DHBs, and research institutes. We don't, unfortunately, fund companies, but commercial partnerships are always encouraged with respect to our research groups. So Richard, you're not missing out. Yeah, so if you're interested in knowing more, head off to our website on CMDT, the CMDT website, and there's a little bit of more of an overview on Te Toki Mataora there. RFPs will come out on the 8th of November for some of our funding. And
Do you want to stick the link on the chat? Just so.
Yep, can.
Thank you.
And then we also are running a BioBridge workshop in AI in health, and that's on the 10th of November. I think in New Zealand time it's 1:30 to 3:30, but Ella can correct me if I'm wrong. So everyone's welcome.
Sounds good.
That sounds good. Okay.
Excellent.
Is that
Eileen, you
AM?
want to talk about something? AM, yes. I'm assuming. Yeah.
Just checking.
Eileen, did you have some news?
I attended the Age Tech conference earlier this month. So that was out of Canada. So that's looking at technology and with supporting older adults and their families. A company reached out to me, Care to Talk. They wanted to see what we were doing down in New Zealand. Had a great discussion with them this morning around the video conferencing technology that they have developed. They're early release stage. Interesting enough, they worked with older adults first to design an app that would be fit for purpose. And then they reached out to providers of health services as the next step. It's all it does is video calling. And, you know, chatting through like why that was, it's like because older people, that's their primary drivers, what they wanted, that's what they told us. So it doesn't have all the bells and whistles. It doesn't have access to the broader internet, and they've locked that down intentionally. For me, it was just quite a novel approach that they'd stripped back the technology to actually just do one thing, and it's basically receive a call or make a call, and it has your contact list that has pictures of people and on an 8-inch tablet device.
Very good.
And that's all it does.
It's like I always wondered whether something like chat roulette would take off with older people. So you know, you have these older people with these devices, and essentially they go and push the button if they want to talk to somebody. Because Sweden did this probably about 10 years ago. Ring a Swede. And so you could ring a Swede from a random number.
It's interesting. What they are proposing to do is also build out a feature that says I want to talk to a doctor, and they have a pool of doctors that have made their schedules available, so you can book a time at any, book a time with a doctor at your convenience to have a video call with them, which I thought was quite novel. We don't have an environment easy like that in New Zealand, so I'm intrigued to probe a little bit about how they've made those schedules available from a doctor's perspective.
Yeah, that tends to be the problem. So, it tends to be either the whole, BeMyEyes.com. Sally, is that such a cool app?
It's just one that I use that connects people. So it connects a blind person to someone who can see to read out shit.
Just interesting.
So I get them to read out the back of the packet in the microwave packet if I can't read it.
That is awesome. Yeah.
Yeah, I know. There's a couple like it. It's a cool app, and I got connected to somebody on the other side of the world who spoke English and just wanted to talk, I think.
Yeah. That seems like a really kind of socially easy thing to do.
There's a couple of things I'm thinking of. I'll start with the news. So it's not quite tech, but you guys might have some good ideas that would help. We got approached by one of the PHOs on the North Shore about, I'm on an area funding committee for St John, and we had a PHO say that, look, our older people can't get to appointments at their GP, at the hospital, things like that. And we've got one health shuttle. But what I wanted to look at was, we were looking at funding a research study that looks at, is what we've got appropriate, because I don't think throwing another ambulance at it is actually a issue. And I think that we need something that actually connects all the providers that offer that, like the Cancer Society, the Deaf Society, everybody who offers lifts to appointments with volunteers actually needs to connect them. So that's kind of something I've been looking at, and with my non-AUT hat on, I've actually approached one of the centres at AUT to try and partner with that with my St John hat on rather than the AUT one.
I think I'd add on top of that, there's like the national travel assistance stuff as well. So from the ministry perspective, we fund people if they have to travel certain amount of distance to.
I think it's 30k from my ED days.
Yeah, but if you could repurpose that, there was a case study done in Wales where there was a little minivan that drove around picking up people and dropping them off, and it wasn't necessarily health services, it was to even take them to the post office and stuff. I'll see if I can dig out the link. It's quite a nice little video, but it's
cool.
how do you pool your resources to make it most effective rather than doing a point to point, do
I
a
know,
group
it's
kind
trying
of
to figure
thing.
out. One shuttle was 6 people. We can't just have 6 people going to an appointment, have someone waiting, and then yeah. And the PHO's kind of brought it up, asking us to fund it and investigate it. So anyway, and Be My Eyes is very cool.
Yes, it sounds very cool, and it's kind of it's that interesting thing about the technology starting to become really easy to use. And so at the point that it becomes really easy to use, people use it for all sorts of things that we never thought. Like, so I a couple of times when we were in lockdown, and I had some stuff going on with the house, ring the electrician and go, I'm going to do a FaceTime call so you can see what I can see and you can tell me what I need to do. And so, it was that sort of you be my eyes and I could see, I just didn't understand what I was seeing. Do you know what I mean? So there's lots of those types of opportunities, I think.
That tech is so expensive. Like, I've got a $3,000 clip-on glasses thing that will read signs, but it was $3,000 I had to pay for.
Yeah.
Sorry, I'll leave it. I've talked a lot now, but I've got loads more I can say about that, about accessibility, VR, and scene examination. So
I can see Ben's put his hand up, and then we'll go to Sav.
All right, Sav, you go first.
Sally, did you have to pay for it out of pocket? Could the Ministry of
some
Health
things are funded and some aren't. Like, for example, I'm getting new pairs of glasses every 3 months. Don't laugh too much. And that's not funded, so I end up paying for that. But I am looking at the moment at getting somebody to give me a hand at work because some of AUT's systems don't work with a screen reader, and I use a screen reader predominantly, and they just do not work.
Yeah.
So I'm trying to get funding for that, but I think you get $1,000 a year to pay for something like that, but you have to meet certain criteria and apply to MSD. So I'm getting a lot of paperwork.
I was going to say some things are funding out of MSD, so it's not an easy channel to navigate for people with disabilities because there's 2 agencies that fund different things.
So
I believe there's going to be an announcement tomorrow about this.
What I got told was by the CEO of Workbridge, who's a friend of mine, to go through Workbridge if you're an individual, because they'll vet it. If you're an organisation applying on behalf of an individual, you have to go straight to MSD, so get the individual to apply. I didn't say that to anyone who's official.
No, but it kind of just highlights the problems that we put in the place of people that actually need stuff.
And
so yes,
they had 10 years ago.
Yeah, so there's going to be an announcement tomorrow, I think, which kind of hopefully will clear up the plan around disability. So watch this space, because obviously some of the stuff's delivered out of District Health Board, some of the stuff's delivered out of Enable is the one that I know, but there's different ones in different parts of the country. That's kind of the equipment side, and then through kind of under 65 NASC services that come out of the ministry, but are often delivered out of District Health Boards or other providers as well. So so there's an announcement coming as a consequence of part of the health system review, and I think that's the announcement's tomorrow. So it was supposed to be at the start of the month, but COVID. Very good. Ben, did you have some news that you want to share?
Oh, and actually, it was just a follow-on from what Sally was saying around the shuttle. When I was at Wakakotahi, there was a couple of the service designers there that went down to Timaru and were looking at trialling the concept of a shuttle service down there, because they were having real issues with public transport, saying that wasn't sort of covering the routes, and like their use had dropped significantly, and they were looking at scrapping the service. And so they were trialling the idea of a having sort of the smaller buses, the shuttles, and whether they could get people round. And I can see if I can get my hands on their research, because I know that
I mean, we've got one shuttle on the North Shore already, but because it's run by St John Operations, they borrow it and put it somewhere else in the city.
Right.
And it doesn't stay on the North Shore all the time. And it doesn't transport people from the North Shore to appointments on the North Shore. It transports people from the North Shore sometimes, I don't know, wherever. So I'm thinking, is there a more efficient way to do this that actually meets the needs of the population, because we've got a hugely ageing population over here. Anyway.
Yeah, which I think, I mean, that was predominantly a lot of the users that were down in Timaru as well. You know, it was predominantly the ageing population that were using it during the day. So I can try and get my hands on that for you if you want, and if not, I can get the lead service designer to at least have a chat with you about what they found, because I think they did some good insights. They put the proposal forward, and then I don't think they got a lot of great uptake from it. So it would be also really interesting to know why that didn't, seeing as it was actually informed by a whole lot of good insights and, in effect, co-designing with the community in the first place. Yeah.
So what I was going to get them to do is a needs assessment first, to look at, an assessment of what's out there already, because I don't think one organisation knows about the other for half the time. Anyway,
Yeah, that's a common thing.
I was going to say, can someone show me how to take my hand down, but it's done, and I was clicking and clicking and clicking.
Yeah, there's just a bit of a delay on it actioning it. So very good. Does anyone else have any news that they want to share from the last month? Okay, that's okay. Speak now, forever hold your peace. I wanted to have a bit of a chat about this new evidence standards framework, which has come out from NICE. Got published a while ago originally, but got updated in April this year. I don't know if people have seen it. Essentially, it starts to try and detangle kind of what is digital health and how do you measure both economic and effectiveness from economic benefits and effectiveness for digital technologies. Now, it's a relatively simple framework, which is kind of interesting, and it talks about tier A, B, and C in terms of technology. So tier A, they talk about being system impact tools. So it's not about an individual person. Basically arguably has no patient measurable outcomes. And so they call them kind of system services, and the description of those are, say, electronic prescribing systems. Now, the interesting thing is, in that first one, there's a lot of conversation about devices that monitor patient vital signs. I'm like, yeah, so it's an interesting thing that it's measuring evidence in terms of whether they work or not, but it doesn't measure the risk of them not working or the likelihood of them not working. So there's kind of still a risk side as much as there's a benefit side. So tier B is then an informed or understanding and communicating kind of tier. And so there's the informed category, which is things like information for consumers. So like a tool that tells people how to self-manage something. So if you're having an asthma attack, you should do this, or if someone's having a heart attack, you should follow these instructions. So that's what they call a tier B inform. There's then health diaries, so people can collect information about their health. And then there's communicate, so allows communication between users and professionals. So that's another category. So instant messaging apps, or the one we've just been talking about. There's then tier C, which is actual intervention. So, and you can start to see these are getting more kind of getting close to the patient and closer to action. But it's kind of interesting because I think they focus very much on the direct action or the intended direct action of the thing. So tier C is preventative behavior change. So a tool that like an online tool that allows you to do smoking cessation, say a chat bot. And then there's self-manage, so tools that monitor or report data to healthcare professionals, so those diabetes glucose monitors I was talking about before. And then there's treat, so a digital tool that provides treatment, which I'm assuming electronic prescribing systems have now gone into there as well. Or CBT was the one that I was actually thinking of, and I can see that in there as well. So CBT, cognitive behavioural therapy, obviously something that mental health professionals can kind of delegate to applications like Sparks. There's then active monitoring. calculations is tier C as well, and then diagnosis is tier C as well. So it's quite a nice way of thinking about it. So kind of tier A is very much all of population. Tier B is kind of a more targeted but still kind of non-interventionist type group of digital devices, and then tier C is kind of ones that affect an individual person. So I quite like that. I suppose the interesting thing in this is it talks about evidence for effectiveness in it, and in some ways there's that related all the way back to the first conversation we were having. There's a difference sometimes between what is clinically effective and then what is actually effective in the real world. And so it doesn't appear to kind of consider the consumer acceptance or the consumer utility that's described with some of these things. So that's kind of a really interesting grey area in the way that they've described it. I don't know if anyone had a chance to have a look at the link that I posted on the Yammer. Seems to me that this is still very, very early. So despite it being first published in 2013 and then updated kind of at the start of the year, there's still a big gap in terms of being able to describe these things and then being able to understand all of the elements of what makes up something that's effective. So yeah,
I needed an app.
What's that?
I thought it needed to be an app.
Yeah.
You could actually follow through, or an engine you could plug your pre-production version into, and it spits out the output.
Good idea, because
like an electronic pick a path thing.
Yeah.
Because it does get quite complicated. So it gets quite complicated, but I don't know how easy it is to parse as to take it from I've got this thing and this is how I measure my evidence for it. So I thought it was interesting because I think it's probably better than where the FDA's gone, because the FDA's gone quite loose on some of this stuff. This isn't a regulator's view on it though. So this is a health system's view on how you might decide to use it rather than whether it's safe. So this is kind of a very different model.
I'm looking at the British standards, John, and thinking that they need some sort of indexing like that in there, because I'm getting very frustrated trying to find the health stuff.
Yeah. I think there's kind of this interesting question about, where do we end up going? So the Ministry of Health's been doing some work on the therapeutic products bill, and so that opens a number of kind of adjunct kind of questions. So there was that starter of the work. I think it started sort of 2 or 3 years ago, and first question: should you have regulation? And I think there's kind of pros and cons to having more or different regulation. There's an interesting thing, because we have very light regulation here, or very little regulation, depending on the way that you want to interpret that. We don't have good regulatory expertise in the country as well. So we don't have lots of people that have been medical devices regulators in New Zealand. So if you were, a startup trying to find someone that's, got experience in regulating or bringing a medical device to market, that's kind of a hard thing in New Zealand. So so I think there's kind of that aspect to it. The other interesting conversation we started to have that was a part of, and this is something that's kind of come up again, part of the process that we were interested in was on the maintenance and security side of things. So this kind of applies more widely in machine learning and AI, where is the version you make available on day one, is the value in making that version available or continuing to make it better? What's the obligations around continuing to make it better? And then also on the devices side, if you're running Windows XP, should you need to upgrade it? Although I did read a really interesting story. There's a guy that wrote the screenplay for the new movie that's coming out June. So with Timothée Chalamet, the guy that wrote the screenplay for that wrote the screenplay in MS-DOS, and an MS-DOS app. I think it's called Star Writer. Well, so his view is that's what he's always done. So he's got some weird old contraption that allows him to plug in this keyboard, but he said it's not on the internet, so no one can steal it. Like, that's probably true. So yeah, apparently it's only 40 pages long. So he wrote the screenplay, and it's so restricted it'll only let you write 40 pages before it runs out of memory. And so he said that's actually turned out to be a real blessing, because he realized if he can't write write what divide a play up into parts which have some name which I can't remember, but if you divide it up and you can't say whatever you were going to say in 40 pages, he's realized it's not going to be a good movie. So that was quite interesting. But yeah,
can we apply that same thinking to like reports and stuff that people write?
Yeah, well, so
Or business cases.
Business case, yeah.
So there's a really interesting story. I've got a friend that was a part of the last government, not that I'm going to say anything good or bad about the last government, but when he was a part of the last government, there was a rule that cabinet papers couldn't be longer than 4 pages. And the reason for that was if you can't convince somebody that whatever you're doing is a good thing in 4 pages, then you're not going to convince them. So more content isn't necessarily better content. And it's slipped a bit, I think, with COVID. But I wonder, you kind of got this balance of the assumption about what people know versus, and therefore trying to fill those gaps so that they understand enough versus what you're actually trying to tell them. So normally kind of Brett's had probably about 4 months of experience in this, trying to be able to tell that story in a very short, or bring people up to speed in a very short way, separate to telling them that what it is you want them to do or what it is you want them to consider. And that certainly is very hard. So making things short is really, really hard for some reason.
Yeah,
it's much easier to make stuff long.
I do think there are 2 sides to that equation. If you've got someone on the other side of the table that you're trying to convince of something and they aren't staying within the appropriate time horizon that fits their role, and they climb into the weeds, sometimes you can miss the mark for all the best intent in the world, and that's really problematic, and COVID has made that really hard. You've got very senior people dealing with very micro level details.
I think there's a really interesting thing in that, because I think COVID was so unknown for so many people. It was kind of like everyone needed to go and learn about it, if you know what I mean. And so a lot of senior people presumably use lots of those processes to learn about it. Do you know what I mean? Because it's not like we were brought up knowing about COVID, and so you could rely on people's inherent knowledge about the fact that we have pandemics, or this is how you respond in a pandemic. I remember last year, one of the first actions I got as the technology lead at the start of last year was to try and convert all of our planning for the CBACS testing centres from DVD to videos that were accessible in the internet age. So we had to go and try to find a DVD player in the Ministry of Health in order to rip the DVD in order to turn it into a video. And by the time I'd done it, all of the DHBs had set up CBACS anyway. So it's kind of like this, we'd made DVDs so that next time we had it, next time there was a threat of a pandemic, we could send the DVDs out. Of course, it didn't really work like that. So yeah, so that was quite entertaining. Hey Robin, how you doing? I see you've joined us.
Yes, sorry.
No, that's right. Are you still on sabbatical, or are you back at work?
Oh, I don't know. What does sabbatical mean? I'm not quite sure.
No comment. We're not allowed. You're lucky.
Well, it certainly meant that you're at this school, so I was curious.
It means you can track Robin down.
Well, no, she found us, Diana. She found us.
No, I can track her down.
Well, you can track her down.
Yeah, you can usually find me. Yeah.
Very good. Very good. So we heard about the trial that Richard's starting at Waitemata DHB.
What's the trial set?
One with the EEG.
The EEG hit.
Oh.
There you go. You're successful when stuff just starts happening and you don't even,
Exactly.
You sound like you're on sabbatical.
Very good. So we were just talking about the nice clinical pathways, Robin, in terms of digital effectiveness and the standards for that. And it does a really good job in some part, but does a really kind of wishy-washy hand what's the thing? Hand wavy kind of job in some other parts. So I was asking the question about how much it would be valuable for us to be looking at something like that. So
Yeah, I mean, I think, yeah, we are doing a bit of thinking about what are some kind of shared success measures, aren't we, Di? That might be useful. Yeah, but it's always depends on the context as well.
Indeed. Yeah, so they talk about both in clinical effectiveness and then economic impact, I think, are the two lenses they apply to it. So yeah, well, it might be worth trying to set up a conversation with some of their team. It seems like they've got a very small team and NICE that look at this, which is kind of a bit similar to us, where it's more focused on the medical device space than it is on, not to say that we've got lots of focus on medical devices, but more focus in the medical device space than in the digital space. So very interesting.
I thought, John, I had a very boring thought, but that was just being able to use it as a very simple, if it was turned into icons or whatever, just being able to look at a Kanban board and know what spread of activity I have. Is it diagnostic? Is it treatment? Is it like, what is it? But but beyond that, I wasn't sure what else it would give me, because clinicians will talk in terms of this is a diagnostic tool and it needs a longitudinal study, or this is a treatment tool, and they'll just tell me. But having it classified might be a useful way of looking at a portfolio.
Yeah, I do like the classification. So of the things in it, I really like the fact that they've got the 3 tiers. I think it's kind of interesting. It would be really interesting to see where we're actually doing innovation at the moment in the health system, because I suspect we're probably not doing a lot in tier B, the understanding and communicating, to be frank, because we kind of tend to focus on what are the clinicians doing, or what is the system doing, not so much on kind of that kind of communicating level. So which, to remind, it was the inform, the health diaries, and the communicate, 2-way communication. So, measuring the benefits of being able to effectively communicate between general practice and specialist care. So we've got pathways that say what you should do, but if you don't, if your patient doesn't kind of follow the pathway in general practice, should you refer them or not? Well, it's easy to just refer them because it's hard to get hold of the specialist. Now, how does messaging help with that question? Another question in that context would be, some GPs do email or message-based consults. What's the evidence that those are good or bad or indifferent? Interesting question. So I think we've got a bit of a gap in that kind of middle understanding and communicating layer. Not to say that there's nothing there, but in terms of kind of how we go about deciding to do things. So there's a website being built at the moment for information around kind of COVID stuff, and there's kind of this interesting question about, well, who's the audience, how effective is it going to be, and how do you know that it's going to be good? So all very interesting questions. Does anyone else have something they want to talk about?
I have something. It's not really much of a thing, but I set up this Slack group that is sort of, I had hoped to be something similar to this for bringing together people who want to work on innovation in the health and medtech sector in New Zealand, including like students and stuff like that. So not just, I guess, people who are quite senior in the health sector, but anyone and everyone who's interested in it. It's got like 60 people in it so far. It's a bit sad. But I was wondering how we could utilize something like that that's a bit more broad, has a more broad audience, and use that as a means for innovation across different, I guess, community groups.
Yeah. What's the Slack called, Sav?
I will post a link.
I think it's this is a really interesting question / conversation. So very much whenever you talk to people, they go, oh yeah, I know what the problem is around a lack of innovation. It's that we don't have the right collaboration tools. Okay, like, holy crap, do you know how many collaboration tools there are? There's just so many, and maybe that's the problem. Or perhaps it's the if you don't know, you don't know kind of stuff. So didn't even know that existed, so didn't know I could use it. and I wonder part of me wonders, there's some of the work we're doing at the moment. We've just turned on last week the I'm going to use the wrong term here, and I realise I'm on the phone call with a bunch of health people. So there was I know what it was. Sorry, I've remembered it. The end of life choice bill. I was going to call it something else. So we've enabled that, and we're busy connecting that to our B2C service, so the My Health account thing that we've been working on, which will allow people that are authorized to do the end-of-life choice stuff to be able to create documents and provide those documents. I wonder how much having that single login might help. So, we know that there are lots of barriers to internet services, and one of those barriers to internet services is the fact that you have to create an account. So if you don't have an account, it becomes a good excuse not to use it. So maybe that's a useful thing. We use Slack a bit, Sav. So we use it with LFPH. So the LFPH, something public health anyway. But they're the people that we worked with on Bluetooth for COVID Tracer, and US organisation. So we use Slack for that, and then we've been using it more recently in the context of vaccination certificates as well. So we don't use it a huge amount. We tend to use Teams quite a lot now, and obviously Teams is a bit tricky because it only works if you're in federated organisations rather than anybody. So that's kind of a barrier. We originally kind of created the Yammer as a way to try and just let anybody with a DHB email address in. So automatically, if you want to join our Yammer, you can, because you've got a DHB email address, or if you've got an email address, we know we can whitelist that, whitelist the end of it. And part of that was also, how do we collect up all of the things we know people are doing, or things that we see that are interesting? And so the search in the Yammer is quite good. I found something for Ben the other day with about, half a dozen keystrokes. So that's quite good because it's got a history of things. So I think there's lots of different use cases, and it's how do we do a better job of bringing people into this type of job? And Ben, I suppose, to target you a little bit in this conversation, because we had this conversation the other day. Ben's new to health. He's obviously not new to technology, but kind of there's this what you don't know kind of problem in terms of healthcare, and even finding out what's going on. So I don't know, Ben, have you got any thoughts about coming from a different sectors where collaboration is a thing, and obviously you do your design meetup thing as well. So have you got any observations or thoughts?
I think I'll probably speak more from the design meetup side of things, because that's kind of what I've been involved in for the last sort of 5 to 6 years. And I think what I think is most effective is actually you need some subjects in which you can bring people together around. So there was one called, in terms of using the Slack channels, there was one called How Might We Do Good that was based out of Australia off the back of the UXNZ conference, and there was actually a group of us that came together and set up a Wellington chapter of it, and we managed to get about, we actually got a lot of participation in that quite quickly, which we were pleasantly surprised about. Did this in the first 6 months, and then just kind of completely died. It was like everyone came out, went sort of really broad on it, and then people didn't kind of know where to go from there and where the actions were. And I ended up winding the whole thing down within about a year and a half. In the end, it was that the challenges of trying to create a community, and I think that's one of the biggest things, is that actually, if you end up just being the person that's continually driving it, then you don't have a community. And it's like, particularly if you've got, say 70, 100 odd members in there, that's one of the challenges. But I found that, where it has been effective, and just thinking there's potentially 2 ways you could go. Once you've got everyone in there, would be like, all right, cool. This is what we are thinking as, say, 3 of the key issues or challenges that we would want to come together around at the moment, and come up with some really nice sort of clearly defined, maybe just a, like a problem statement, or you get old nicely crafted how might we kind of statements. And then again, you could still potentially have another open channel to be like, and does somebody else have, something that that could be if people actually have ideas that they want to bring in, or there's particular challenges that they're seeing within the health area. It could be like, you know, something with a family member or something that they're seeing as well. So you'd have your, potentially the two ideas on it. We were using Slack on it, and I'd probably say the How Might We Do Good one was probably one of the best ones I've seen, and they had about 10 very clearly defined channels like under it, so you knew, you know, if you wanted to go in there and look at resources or events and stuff, it was all lined under there. But again, it's like any of these things, what it becomes is just yet another digital channel that you're having to monitor and stay on top of. And so I honestly, I haven't nailed this. I've been trying to land this for the last 5-6 years. I mean, I've used the meetup groups. I've just honestly just tried setting up my website. I've created LinkedIn groups and stuff, and all to varying and I'll have to say pretty limited degrees of success. At times, yeah.
I did read online that usually these communities of practice, they do have like a limited time frame in which they are active and thriving, and then eventually they like dwindle out when their purpose has been served, and perhaps it leads to other little babies emerging, communities of practice, little baby ones.
One of the things that I haven't tried yet, and that I guess like looking at say a group sort of this size as well, was that I'm kind of keen on is the idea of sort of like thinking of like circles of influence, and it would be like if you've got sort of people in there, like you create in effect like subgroups of like, you know, say 6 to 8 people, which, you know, same thing when you're running a workshop and that kind of stuff. That's always your, you know, that's an ideal kind of number for ideations and things. And then you go, all right, cool. So the emphasis then on those 6 people in there is like, right, you need to go out there and now, you know, create your own sort of circle, or whether it's just 2 or 3 people in that, and that's how you could, you know, sort of slowly start building out the network from there as well. So again, really like that idea. Haven't put it into practice yet, so I can't tell you how it's done.
Ben, sorry, I was wondering, Ben, about comparing this challenge with what can happen inside large organizations. Like 3M has a structure where I don't know if it was departments or divisions had a certain amount of innovation budget, and so individuals could pitch, and so they would come up with an idea, they were encouraged to network, and then they would pitch, and they would get to a certain size because they've got other departments interested, and that's how they would get their funding. And I wonder if these communities, which are so much out in the community, they need a little bit of wind in their sails. So how do you give them wind in their sails through funding to let them do the $5,000 prototype or whatever, $50, I don't know what the amount is, but entrepreneurship seems easier because you can apportion a slice of profit to innovation funding, allocate it out and let people go for it, than something that is so genuinely community driven, because at some point people's, I don't know, goodwill or interest might fizzle and they might not be able to bring the resources that they need. I just wonder if there's an entrepreneurship overlap that we could bring.
I like that thought. I really like that thought, Justin, in the sense that we're doing you should all probably know this, but we're doing some work on what innovation with, as a consequence of health reform, will look like. And so some of the questions that we've been trying to answer in that, and we'll have a document come out to most of you at some point in the very near future, hopefully kind of gives us a starter for 10 in that. So it's an active question with ministers at the moment. So they did a bunch of investment around the COVID Innovation Acceleration Fund. And the question we're now being asked is, well, how come they were able to do those projects and then the health system just hasn't bought those things? So Robin's aware of one of the projects, but they've invested in maybe 30 or 40 different projects, and either no one told them that, you know, the likelihood of success is low, or, you know, this is how the health system actually buys things. So yeah, it's a really interesting kind of question about how you kind of support that to happen, because if you get too close to government, you end up running RFPs that take forever in order to give out very little money. So yeah, it's a really tricky problem statement. And then of course, you know, the RFP has to have all of the measurable benefits and outcomes that the government definitely wants. And so you end up creating contracts that are monsters to give out very, you know, very, very little money. So yeah.
The framing with RFPs though is it's a return on investment framing, and what we need is a return on portfolio frame.
Yeah, totally agree. So hopefully what we've been putting together kind of gives that will give you guys a little bit of a sense of that. Last thing I wanted to talk about, we've just finished some work. We're going to deploy probably what is our biggest power app to date in the ministry. So we have a business process that exists in the ministry, which is around approving forensic mental health patients' movements and or leave. And so we built a power app to replace what was in Lotus Notes. So for those of you that like that joke about the Ministry of Health having Lotus Notes, we've still got it, and it's still been doing a bunch of document management stuff. So this is kind of the first cab off the rank. Mary and I have been working on it, and so we'll be doing a demo internally on Monday afternoon, and it kind of shows in a pretty useful context for health what we can be doing. So that'll go live not next week, the week after. So we'll be doing a data migration out of Lotus Notes as well, because it turns out the SharePoint search is really good. Yes, Lotus Notes. No, older, Sally. We've had it for way longer than the iPod. And so we're pretty proud of the fact that we're going to be able to get rid of it. So if we can do more of what we've just done now, which has only taken us about 8 weeks work to build production capable solution and place this kind of business solution. So, and you can spend as much money and build as complicated as thing as you want, probably with Power Apps, but no, it seems to have gone pretty well. So if anyone wants me to share kind of the demo video, I can show you that, and you can see kind of what sort of stuff we can build. So, very good. Got only a few minutes left. Did anyone else have anything else they wanted to talk about before we wrapped up? Diana, was that you raising your hand? No.
No.
I guess a question I have a question, John. Is there anything you would like us to bring to our next catch up? Like, what would you like from us?
Yeah, so I think the key thing is just most of this is about what's going on in the sector. Does that make sense? So what are the things that are happening? Because I think the risk we currently run is that things go on and we're all too busy to take the time and kind of reflect on what we're doing, and or in often case we end up doing the same thing twice. So just trying to make sure that we've got a sense of what each other's doing, and or try and build that conversation a bit more into a broader, more inclusive one. So it would be good to get Richard Perry along to this, for example. So I might send him an email and ask him to come along next time. Not so much that people have to contribute, but just so that people get a sense that the community is bigger than maybe they thought, or is more diverse than maybe they thought, or there are people that could help you because they've come from a different kind of perspective. And, you know, sometimes it's good to just have a bit of a chat. I think particularly kind of where we're at in the ministry at the moment, where we've got into quite a delivery mindset, particularly in data and digital, where I spend lots of my time doing delivery stuff and not enough of my time in these types of conversations, which is what are other people doing, and what could we do and what should we do, rather than what are we doing. So
okay.
Does that answer the question?
Oh, it does, absolutely, John. Oh, yep, absolutely. Thank you.
Cool. Not a problem. Excellent.
I should probably share something then when we've got a few minutes left. I wasn't quite sure because a lot of stuff we do is not so much in the digital and data space, but I guess it's in the innovation, maybe in devices. So shall I just whip in a couple of minutes? Is that right, John? Okay. So we've recently just held an IP strategy workshop with our medical physics and bioengineering team to sort of look at trying to develop a shared process for IP and strategic assessment of the clinical prototypes. So they get approached by a lot of clinicians for sort of one-off bespoke devices to help patients, or particular patients, and we're sort of looking at what processes and pathways could help get some of those patient care innovations out to more patients. So not necessarily just commercial, but also, you know, what's the sort of the IP, the risks, the regulatory around how could we share those designs in case other people wanted to pick them up. But then also if they would potentially have some commercial scale ability in the future, how do we, use the patent hacks and the various tools that might help us use the clinical trial process to protect that a bit earlier on. And so I guess yeah, that's one I'll follow up a bit with you anyway, and Diana, to
That'd be really good. I was just writing a note to myself.
Yeah. The other, and so in a different event, we're doing a Christmas event this year on which is a networking one around carbon zero. So obviously the carbon zero target, and so we're showcasing some innovations or technical innovations from the Canterbury University, Otago, CDHB and ARA, who are the 4 sort of partners in the health precinct down here, but also getting some local industry along. And we'll be streaming that one. Obviously, everything has to be streamed now, as well as hopefully some in-person drinks. Yeah, but it's always good to hear what others are doing in the DHBs on that environmental sustainability side, because it gets dropped a lot with COVID at the moment overtaking. And this week, which John will know all about, I learned all about headless websites, security, design, testing, Docker containers, cloud research, cloud risk assessment, all for doing a website to just sort of put a digital stamp out there. So I thought, yeah, understanding and learning a bit more about best practice in website design for things that aren't even patient facing was quite valuable, and hopefully when we get the spec out of that for that project, we might be able to share that if it's of any interest, because John's helping us on that side. But it was quite an eye-opener. I thought websites were a fairly simple.
Well, they are and they aren't, and they're more and less commodity every day, if that makes sense. So they're more commodity and less commodity, because of course commodity things look the same and people want websites to look different, but at the same time the same thing makes them secure, and doing things differently makes it harder to secure them. So yeah, it was a good conversation. Okay, well, we might call it there. We're at 3:59, so have a good couple of weeks, and bring along things that you're doing next time, or things that you've seen that interest you, because I'm sure you all read widely, and I'm pretty sure you're not reading the same things I am. So yeah, bring those things along, save them up and bring them along. We can talk about them. Thanks a lot, guys.
Thank you.
Thank you. Nice to see you all.
Have a good weekend.
Nice to see you guys.
Thank you.
Have fun, everyone.